Imagine a wound slowly healing over time, leaving behind a scar that eventually fades from memory. But what if years later that very scar harbors a deadly secret? That is the story of Marjolin Ulcer, a rare but aggressive skin cancer that emerges from the shadows of old wounds. In today's video, we will explore Marjolin Ulcer, cutaneous malignancy that begins innocuously but carries a lethal prognosis if not recognized early. This condition is most often seen in chronic wounds and long-standing scars, especially those from the burns. Named after the French surgeon Jean-Nicolas Margin, who first described it over 2 centuries ago, Marjolin ulcer remains a challenge in both diagnosis and treatment. So, what exactly causes a Marjolin ulcer? The most common trigger is a burn scar, allowed to heal by a secondary intention, with malignant transformation occurring in 0.7% to 2% of these scars. But it can also arise from chronic inflammatory conditions and traumatic wounds. For example, venous stresses ulcer, osteomyelitis, pressure ulcers, Asian dermatitis, in repeated irritation, local immune suppression, and genetic factors combine leading to malignant transformation. The most common type of cancer found in these ulcers is squamous cell carcinoma, accounting for about 80 to 90% of the cases. Immunologically, margarine ulcers can occur across all age groups, sexes, and races, though they are more common in men with a ratio of 3 is to 1 due to high frequency of burn injuries in male patients. The latency period between the initial injury and the discovery of malignant degeneration averages 30 to 35 years, with the typical age at presentation being around 60 years. Unlike the other skin cancers, the risk of developing a margarine ulcer is equal across different races and ethnicities. Now, coming to pathophysiology, the exact pathophysiology of margarine ulcers remain unclear, but several mechanisms have been proposed, including chronic irritation and repeated reepithelialization, local damage to immune mechanism of the skin, genetic predisposition, toxins released from the local cell damage. Burn scars, which tend to be raised above the skin, can cause chronic irritation and impede the local lymphatic and vascular functions, contributing to the development of the malignant lesion. Histopathologically, squamous cell carcinoma is the most frequent identified malignancy in the marginal ulcer, accounting for 80 to 90% of the cases. Other histological types include basal cell carcinoma, which is approximately 9 to 10%, melanoma, which is 2 to 3%, and in rare cases, sarcoma, dermatofibrosarcoma, mucoepidermoid carcinoma, and leiomyosarcomas histologically be present. Clinical presentation of marginal ulcer is typical presentation as a non-healing ulcerative or indurated lesion in a chronic wound or a scar. If we see the clinical presentation, a marginal ulcer typically presents as a non-healing ulcerative or indurated lesion in a chronic wound or scar. The lesion often appears tall swelling with rapid growth and rolled elevated margin. Additional clinical signs include exophytic granulation tissue, bleeding, regional lymphadenopathy. Marginal ulcers most commonly affect the lower extremities but can also occur on the scalp, torso, and face. The form of marginal ulcers is more common and aggressive than the exophytic form. Early recognition is very crucial. Any suspicious non-healing lesion should be biopsied immediately. Physical examination of local lymph node is essential, and imaging studies like ultrasound or CT scan may be required to assess for metastasis. While there is no specific TM classification for marginal ulcer, staging often follows the guideline for the underlying malignancy, usually the squamous cell carcinoma. When it comes to treatment, surgery is the cornerstone. Wide local excision with clear margins typically involves 1 to 2 centimeter margin to ensure complete removal of malignancy. Mohs surgery for cosmetically sensitive area is often recommended. In advanced cases, amputation might be necessary. Lymph nodes dissection remains controversial, but it's considered when nodal involvement is detected. Adjuvant radiation and chemotherapy are option when surgical resection is not feasible. The agents used are 5-fluorouracil or platinum-based therapy for the adjuvant chemotherapy. But even with treatment, marginal ulcer carry a poor prognosis with a high rate of recurrence and a 5-year survival rate of only 40 to 60%. Early detection, thorough surgical excision, and close follow-up are the key to improve the outcomes. So, what can we do to prevent this silent killer? The best approach is vigilant care of chronic wounds, especially burn scars, early excision and grafting of the burns, regular monitoring of scars, and educating patients about the signs of malignant transformation can make all the difference. Marginal ulcer may be rare, but their impact is devastating. As a healthcare profession, staying informed and vigilant is our best weapon against this hidden enemy. Let's commit to making early detection a priority not just for ourselves, but for every patient we encounter. Stay vigilant, stay live, subscribe for more medical insight, share with your friends. Thank you very much.